This lecture is on urinary tract infections. To begin with some definitions, firstly there's uncomplicated UTI. This is defined as infection in a non-pregnant woman with a structurally and neurologically normal genitourinary tract. Complicated UTIs are in all other people. That is, infection in a male, a pregnant female, or anybody with a structurally or neurologically abnormal urinary tract or an indwelling catheter. Upper UTI or pyelonephritis is an infection that reaches and inflames the upper urinary tract, that is the ureter collecting system and renal parenchyma. This picture nicely shows the different pathogens that cause UTI. This is a chromogenic agar which changes colour to indicate which organism is present. E. coli is the commonest cause, followed by Klebsiella, and the others as listed. Clinical features of UTI. To begin with the symptoms, they are frequency, urgency, dysuria, and suprapubic pain. But notably, there can be atypical presentations, particularly in the elderly, who may not have these symptoms, but may just present with acute confusion, for example. In terms of signs, there may be suprapubic tenderness, there may be fever, and there may be renal angle tenderness, particularly in pyelonephritis. The first test to do is a dipsticks. These are fast and cheap and have a good negative predictive value. Urine culture should be done under certain circumstances. It should be done for all complicated and all upper UTIs. And in patients with uncomplicated infection who've had recent antibiotics or have persistent or recurrent cystitis. And in patients who have clear symptoms of UTI but the dipstick is negative. Blood culture should be performed in patients who are febrile or if you're suspecting an upper UTI. This flow diagram shows you how to treat an uncomplicated UTI. You first need to be sure there are appropriate symptoms, plus evidence of infection, which might be on the dipstick, which is positive for nitrites and leukocytes, or greater than 1+ of leukocytes on formal urine microscopy. Typically appropriate antibiotics are ciprofloxacin, given orally for 3 days. The approach to a complicated UTI is to look for signs and symptoms compatible with UTI and for a urine culture to have greater than 10⁻³ colony-forming units per mil. If this is true, then you should choose your antibiotics as per the uncomplicated UTI algorithms. And once culture and sensitivity results are available, you should de-escalate to the narrow spectrum antibiotic that's available. Duration of therapy should generally be 7 days for patients with cystitis and a rapid response, and up to 14 days if there's delayed response or pyelonephritis. And in patients who you consider urinary tract abnormalities, you should perform appropriate investigations. For the management of catheter-associated UTI, you must always look for compatible signs and symptoms or a sepsis syndrome. Positive dipstick for nitrites and leukocytes, or greater than 1+ of leukocytes on formal urine microscopy. You must always replace or remove the catheter and send urine for culture. Then ask yourself if the patient is stable with cystitis and absent systemic signs of infection. If the culture grows less than 10⁻³ organisms, then no antibiotics are required. If they grow greater than 10⁻³, then you should start appropriate oral antibiotic therapy. If the patient is not stable or has signs of systemic infection, then you should do a blood culture and consult local resistance patterns for your choice of empiric therapy, which should usually be intravenous. You should de-escalate to narrower spectrum antibiotics once culture and sensitivity results are available. And as for complicated UTI, 7 days may be appropriate if there's a rapid response, and 14 days may be necessary if there's a delayed response or pyelonephritis. It's not always easy to determine clinically which patients have pyelonephritis. They may have suggestive symptoms such as costovertebral angle pain and tenderness and often fever, but sometimes these can be absent. They will always have evidence of infection, be it a positive dipstick or positive leukocytes on urine microscopy. If these are absent, then you should look for another cause of the symptoms. You should always send a urine culture and then start empiric antibiotics. Ask yourself, is the patient severely ill or unable to tolerate oral antibiotics? If not, they can be treated as an outpatient, and ciprofloxacin orally is usually appropriate. If they are ill or unable to tolerate oral therapy, then they need to be an inpatient. An appropriate empiric therapy might be ceftriaxone or an aminoglycoside such as gentamicin or amikacin. You should, as ever, be looking to switch to oral therapy once there's a clinical response in effervescence and fever, and dependent on the culture and sensitivity results. If you're using ciprofloxacin, then 7 days is usually sufficient. If you're using cotrimoxazole or beta-lactam for definitive therapy, then therapy should be extended to 14 days. Asymptomatic bacteriuria in pregnancy is a condition which requires special attention. All pregnant women should be screened for bacteriuria because they're at increased risk of pyelonephritis later in pregnancy. So to make the diagnosis, you perform a midstream urine, and any culture showing greater than 10 to the 3 CFUs per mil of a single organism or any E. coli is significant. Urine culture should be repeated to confirm the diagnosis. In management, this is one of the few times in antibiotic stewardship that we treat patients when they have no symptoms. However, in this case, all patients should be treated with an oral antibiotic appropriate to the bacteria that's been cultured for 5 days. We rarely perform follow-up cultures to confirm sterility, but once again, this is the exception to the rule, and we should do this to make sure that we've eradicated the bacteria. Cystitis and pyelonephritis in pregnancy is also a special case, although the same principles apply as for non-pregnant patients. Of note, ciprofloxacin is contraindicated in pregnancy, and coamoxiclav can be used before the 3rd trimester, but in the 3rd trimester it's preferable to use cefuroxime due to the increased risk of necrotizing enterocolitis in the infant if coamoxiclav is used at this time. So in summary, uncomplicated UTIs occur only in non-pregnant women with normal urinary tracts. The most common pathogen is E. coli. The diagnosis depends on signs, symptoms, and results of urine testing. Urine culture is only required for complicated or recurrent infections, and complicated UTIs require a longer duration of therapy.